Hi, everyone, and welcome to this very special presentation of the Global P.A.D. Impact Awards brought to you by the Global P.A.D. Association. Today, we're honored to announce America's Limb Preservation Team of the Year, which is the Limb Preservation Society of El Paso, Texas, led by Dr. Laiq Raja and co founded by nurse practitioner Lorie Henderson. This team has just how I feel is revolutionized. I use that term very lightly, but I really believe that they've revolutionized limb preservation care through their innovative 24-hour foot emergency hotline and seamless coordination of care across multiple hospitals and specialties. Board members Luis Fuentes and Rosa Marquez have also been instrumental in breaking down barriers as well between the medical specialties to create truly integrated care through this Limb Preservation Society. It is pretty incredible. Their multidisciplinary approach has not only transformed patient outcomes in El Paso, Texas, but has established a model I believe is worthy of national recognition. And today we are speaking with Dr. Laiq Raja about this remarkable achievement and about the program. And I know we've had you on before, Dr. Raja, but you continue to just do great things with the Limb Preservation Society. Congratulations, well-deserved honor.
Thank you so much, Kim, and it's an honor to be elected for your award. My team, all of us are very excited, and thanks again, and we very excited.
Yeah, so what inspired the creation of the Limb Preservation Society in El Paso? And, what were the initial challenges that you faced in setting up this organization, which is a nonprofit, I might add?
Yeah, so Limb Saver Society, we actually started about 3 or 4 years ago. And that was sort of a gradual process. Once we had this, our CLI program, and we were running it, and we had a lot of patients coming, and we were treating them. And we started noticing that financial issue was very important for many of these patients.
Yeah.
We treat them and we revascularize them, and then sometimes they don't have enough resources for medications, transportation, going
Yeah.
to see the physicians, and the family member bringing them. So we decided that we should have nonprofit Limb Saver Society so that we can get grants and help from other organizations, and we can utilize those finances to help these patients. And of course, you have been one part of that.
Yes, I love it. But throughout one of the crux of really, I don't know where it falls with the Limb Saver Society, where you have that 24-hour foot emergency hotline. And I think that it's just a game changer. I want you to explain how that system works and the impact that it's had on patient outcomes.
Right. So I think one of the important thing to have a very well structured program, in our case, a CLI program, is the patient could reach out to us whenever they want to, right? So we decided that we need to have 24 hours hotline where they can pick up the phone, and one of us is always available. Alejandra is available most of the time, and our other colleagues. The importance is just to first talk to them and see what exactly is the problem. Is it very acute, or it can wait? Kind of triage them quickly. And then if they need to be seen by us within 24 hours, they get appointment to see me or one of my colleagues, and go from there. Now, if we think something is very urgent,
Yeah.
particularly like acute limb ischemia or things, then we usually direct them to the hospital where our CLI program is. And we usually call the hospital, tell them these patients are coming, and then we treat them in the hospital.
And so it takes a lot of coordination across multiple, facilities and practices and doctors. That can be really difficult. How has your team managed to create a seamless system that overcomes traditional healthcare silos that can lead to amputation?
Right, as you are right. So there are different components to this. So first is, of course, developing a very structured program. We know we have TAVR programs, right? So you have a valve program where there's a surgeon, there's a cardiologist, there are navigators, and there's other disease states you have program. But CLI still is in early stages. So we decided that first of all, we need to create a very well-structured program. So we invited colleagues from different specialties, vascular surgeons, cardiologists, orthopedic surgeons, wound care, podiatrists, all of them who are somehow are part of these patients. And we developed a committee, CLI committee
Yeah.
in the hospital. And the purpose is to start creating some bylaws so that there is some sort of a standardization, which is very, very important for anything which you do. So eventually, all of us, we created different protocols, and one of the important part was to create a position for a navigator. So what navigator, usually it's a nurse or nurse practitioner, is that to kind of navigate patients in this group of physicians and all other people. For example, in the hospital, I have a Julie Baruman, she's exceptional, just like Alejandra as an outpatient navigator, they're exceptional. So when the patients, they get admitted to the hospital, so we have protocols in the emergency room under CLI consult. So the ER physicians, when they see a patient with any kind of a leg problem, wound, or anything, they just click the CLI protocol. And the message goes to our CLI coordinator, Julie. And right away, they do some basic studies, arterial Doppler studies. They come examine the patient, and then we get involved right away. And at the same time, the other specialties, the podiatrists, wound care physicians, so they are, everything goes kind of simultaneously. The purpose is how can we save time?
Yeah.
Almost
Time is
all.
tissue. Time is tissue.
Exactly. And then, you don't want patients sitting in the hospital for longer than they need to.
Mm-mm.
So usually within 24 hours, almost all of them, they get their initial angiogram. And after the angiogram, we sit down and decide what's the best way of treating these patients.
Yep.
Most of the time is endovascularly, but if the surgical option is better, so we have colleagues, surgeons, they look into that, or hybrid, or whatever we decide. And then the patient undergoes maximal revascularization, or really wound directed. That's the whole important part is you want to do a revascularization, but you want to do something which really is most effective inline therapy. After revascularization, then these patients become a part of, we call it circle of care. So what the circle of care means is that they are seen by the wound care physicians right away, and then the wound care gets started, and then depends if the patient has some other issues, for that they need to be in the hospital. If not, they are transferred to the extended care if they need that, or outpatient. And if they go as an outpatient, then we have home health, 3 or 4 companies who does really good vascular work, follow wound care work.
Wow. That's
As
rare.
Right. As you know that, home health, they do everything, but we need somebody who's doing particularly this. Like we have a heart failure home health, which does really good heart failures. So these are actually, you'll be surprised that these agencies are picked by us and we train them. Like
Oh, wow.
Alejandra, Adrian, we give 2, 3 teaching, you know, lessons or
Seminars. Yeah.
and they come in, they sit on, we talk to them, give them a whole P.A.D, CLI, wound care, everything, so they feel comfortable that this is what we expect. Check the
Yep.
pulses, check if there is any problem, so they know that if there is any issue they call us right away. So at the
You're
same
making
time,
so many people jealous that, gosh, we wish we had your coordination everywhere. But what unique aspects of El Paso's community did you really need to address in your approach to limb preservation, and how might these lessons apply to other communities?
well, I think it's doable for sure. And I can tell you, like any other disease states, if one wants a good outcomes, they have to have their team. Particularly this disease state of peripheral vascular disease and critical limb ischemia, because it's not a one-man show. And I learned that years ago that, I can do the best possible, but then if there's no one else involved in it, the outcome probably is not going to be the
Yeah.
same.
Mhm.
So, I mean, there are a lot of physicians, they are very motivated, and I'm very glad we go to these conferences, we see a lot of physicians, nurse practitioners. I think the concept of multidisciplinary approach is been there now. I think everybody knows that I think we need to have a team. It's just that sometimes it takes a little difficult to create a team.
Yeah.
You have to have a committed, passionate physicians, nurses, nurse practitioners who want to do that. For example, one of the things in this program is that we are not hospital employees. All of us, we have our private practices, and we are not mandated that I have to refer this patient to this podiatrist or this thing, nothing. Everything is done because we've been working together for years, and we have the same goal, all of us. So it runs very smoothly because we are not under pressure,
Yeah.
and we do the outcome measurements. We've been calculating for the last 4 years different metrics, which is part of, as you were telling, that our program is one of the TWO's Joint Commission Accredited Center of Excellence.
Yep.
So one of the requirements we have is that we have to collect the data and we have to keep submitting every year. And nationally, if somebody shows up in the hospital with CLI, the chances of having a major amputation is about 15%. And for the last 5 years or 4 years, we have shown that in our institution, where we have a pretty busy program, we do a lot of procedures, it's less than 5%.
Wow, that's pretty incredible.
Yeah, and this all depends, it's all related secondary to our team.
Yeah.
Everybody working together, things done quickly, evaluation, treatment, and then follow up. You need to follow these patients. If we have a protocol, I see them in the office within a week after the procedure. Then they are seen every month. In a month, to
Hmm.
get an ABI, arterial Doppler studies, then 3 months, 6 months. And in between, if there is a problem, patient has a recurrent symptoms, they are seen right away and they go to really thorough evaluation again. So we know that this is a disease we are not curing. We are treating them, but there's a high likelihood it might have a recurrence of this disease. So we need
Yeah.
to be really proactively looking for it rather than, waiting until things are kind of
That's
too
why I love that
gone.
you guys are also on the front lines. You're trying to raise awareness. You have your Pause for P.A.D program, which we're going to highlight this week on our Collateral Nation
That's right.
podcast on Wednesday morning. But you try to come up with different initiatives to get the word out in the community. There's an event coming up where I'm very excited to come and honored to be a speaker at your annual event in December, where you invite all kinds of physicians and clinicians throughout your community to help raise awareness of PAD so we can get these patients diagnosed sooner, which is critical when you think about this, what I call a type 2 PAD, not the traditional PAD that we're used to with textbook intermittent claudication. We have this diabetes and chronic kidney disease driven PAD, which is more of a bottoms up disease, and it does not present in the early stages with intermittent claudication as we would normally suspect. So it's really important that these physicians and clinicians, through your educational seminars, are trained to look for it. And for people with high risk factors like diabetes or CKD or ESRD or even heart disease, smoker, whatever it is, that they actually take off the patient's socks and feel those foot pulses.
Yeah, I mean, you're so right that, yes, all this, what we are doing is continue to increase the awareness.
Mhm.
And as you said, we have for the last 4 years, we have a yearly conference called CLIF, which is CLI Fighter Conference, which is again is a multidisciplinary conference. We invite different specialties, and again, the purpose is to give a message that how complicated this condition is and different aspects of it and education.
Yeah.
Actually, we are doing in November our first fundraising gala, and we are proud of all my team, which is again set up just for the same thing that come down, have some fun, but at the same time, the background will be again about peripheral arterial disease, talking about the same and see how can we create more awareness and at the same time have a good time.
Yeah. So looking ahead, before we're going to get to a few questions. So if people have some general questions, every time we have a physician on or a clinician, we do like to get to questions from patients in our network that might have a burning question about their own situation. Of
Sure.
course, you don't have all their medical records, so we're not here to give medical advice, but just to offer some questions they can ask their doctor or some general education based on the questions. But before we get to those, looking ahead, what do you see as the next evolution in limb preservation care, and how is your team preparing to meet those challenges?
Well, we are continuing to do the same, but we continue to spread. And our goal is that how can we create or help to create these kind of a program nationally? I think that's one of the best way of combating this, deadly disease and this extensive amputations going on. So we are hoping for the next few years we will continue to grow and
Yeah.
continue to be partnership with different physicians, different hospitals, and give our experience and our input to create these programs. At the same time, we are also involved in multiple different clinical trials. Our goal is that how can we progress this this field of CLI and peripheral vascular disease, and creating some new techniques, new technologies, which eventually end up helping those patients. So we are looking into the future and partnering with different industries, different companies
Yeah.
to how can we uh, be involved in something new devices, new balloons, below the knee these devices, And the good part of that is that, of course, it keeps us up to date for what's happening. Another thing is we are able to provide our patients a technology which is not even available in the market.
Yeah.
And of course, as you know, that when you are part of the clinical trial, the surveillance and the follow-up is a little bit more controlled. That also helps to have a better outcomes.
Yep. Totally agree. Okay, a couple questions here, and then we have 6 questions we ask every single one of our awardees. Donna, she walks and walks. I've been so proud of her over the past few years. She has a 10 centimeter full blockage from the SFA through the adductor hiatus. She's wondering, in case she ever needs it right now, she seems to be doing great, walking 3.5 miles in the morning, 3.5 miles in the evening. Don't you wish every patient would be as a walkaholic like that?
Excellent.
Pretty
Excellent.
incredible.
Yeah.
She's really taken the bull by the horns, healthy eater and all. She's doing great. But you know what? In case she ever needs it, I mean, this is a progressive disease. Um, what are some of the new technologies that are, that might be relevant for her and for others, maybe moving forward in case she ever needs them?
Well, first of all, I think if she's walking 3 miles, gosh, excellent. She should continue to do this, and I do not think she needs any sort of a revascularization procedure. She has excellent collaterals, and she's getting good flow. So, having said that, if in the future something happens and she becomes more symptomatic even after on this exercise program and the good medical therapy, that's what we recommend to all our patients, particularly with claudication. When there is no tissue loss, there is no wound. So technology has improved tremendously. So there was a time when crossing these long occlusion was difficult, and we used to struggle, and that most of the time this is now past, and crossing and treating the opening the artery is not a real challenge. But again, the challenge continues to prevent this artery closing back again. So in that field, we do have different devices. In the beginning was just balloon angioplasty, which hardly anybody uses because there's a lot of recurrence, more than 50% that are back very soon. So we have different atherectomy devices, which are devices which literally remove all the plaque so that you have least amount of plaque inside. And then we have this drug-coated balloon technology, where these are balloons which are covered with this special anti-restenotic medication. When you inflate the balloon, the drug gets into the vessel wall and prevents this tissue growth again. So it's becoming much and longer lasting effect of the procedures. We have a drug-coated stents available. So we have multiple different technologies available, and all of them always thinking of how can we prevent recurrence of the disease or
Yeah.
prolong those arteries which we open. So yes, if when the time comes, she can research. The main important thing is to look for facilities, hospitals, physicians who do this. Physicians or hospitals who do more, they are better. It's just like anything else. You have to do a lot of it to get better in it, right? So you have to figure out who is CLI specialist or vascular specialist, because same field, I can talk about me, cardiologists, interventional cardiologists, some are doing coronaries, some are doing heart valves, some are doing something else, some are doing vascular. So you have to find which cardiologist does what, and
Yeah.
then try to look for the one who does more endovascular procedures, and you can look at their outcomes, and research is very important to find a right contact so
Yep.
that they do a good job.
What about, just the minimally invasive? Have you used P.A.D?
Right. So I did Friday.
You mentioned. Oh, you did. Oh,
Yeah.
you did one.
Yeah. Paige was here. Actually, he was telling me about you that you're gonna interview somebody who has, I don't know, 5 years or more than 5 year patency of the PTAB.
15 years. We have someone
15.
that was
My God,
15 years. He was the very first patient, and he's still patent.
it's unbelievable. It's a great technology, and yes. So as I was mentioning, that all these technologies eventually help us to treat patients who are not considered to be candidate for anything. So yes, I have done few PTAPs, and I'm very actively part of the DVA and TAD-V
Yep.
procedures and lymph
Yep.
flow procedures, which is another great addition to the patients who are considered to have no option, and they were considered to have major amputations. And looking at
We
you
just need
know
insurance companies to keep up with
right,
the new
well, they are
technology.
right, exactly. So yeah, it's a very exciting times, that the way the technology, the different companies are coming with different devices. We are part of many of them. So yes, the future is excellent. And
Yeah, we're really
I
excited.
think
There's so much,
I don't think
so
anybody
much
should have
good stuff.
amputation anymore. We have available
No,
to everybody. Yeah.
it's just, we always say, unless life is on the line, and you always get a second opinion before amputation. There are patients that ended up way too late, and there's just, I mean, I still even think, we had a vascular surgeon on the other day, and he said, well, if there's too much pain, but even then you can send the patient to an interventional radiologist that specializes in pain management, and they can do injections into the sympathetic nerve. They could do so many different things for pain management these days, in minimally invasive ways. You have the stimulators that go into the back, and
Yes.
so still everything should be exhausted beforehand. And that's why I love what you guys are doing with the Limb Saver Society and your entire CLI program there in the El Paso area, is because you really do take a multidisciplinary approach to care for patients with PAD. And we have Marie that is asking a question about an incision that she had. It's just not quite healing. And I was able to, while we were sitting here, get on the text with her doctor about making sure that she gets to wound care. And we see this all the time, Dr. Raja, and this is something that you mentioned early on. You
Mhm.
have to have regular wound care, and consistent wound care, wound care by people that are knowledgeable, trained for PAD, um,
Absolutely.
and diabetes, to be caring for these wounds, these incisions, so that you can make sure they heal. And someone needs to be accountable for what I call the ringing of the bell when that wound is healed. They need to be consistently following these patients, right? It's not
Yeah. So
normal.
it's extremely important to find the right wound care physicians. I agree with you. We have seen some, they just tell you they are wound care doctors, but their expertise are not up to date. And then you pick some of them, and then we work with them very closely. The way usually it happens is that, when we do, or they refer to us or we refer to them, and once we are done, they are doing the wound care. And anytime they think there's a stall, there is something not right, I get a call, or my team gets a call right away. Doctor, there's something wrong, and uh, the wound is not healing. It used to be. So that's kind of a communication is very important. So we see them, and if there is any issues, we resolve that, revascularize them if it's needed, and then they go back. So it's all the time texting. We get texting. Alejandra, Adrian, all my group gets texting all day long.
Yep.
And this is how we communicate, and creating a program. That's one of the very important part is availability. You need to be available all the time.
And it's
Uh,
just passion. I mean, and when you split it up between everyone involved, I think that, it can be, and a lot of patients, if the doctor gives you their number, you need to use it in case of an emergency or to prevent an emergency. They want you to. Don't wait until
yeah,
it's too late. I hear all the time that patient, oh, I don't really want to bother them, because they also say, like, I don't want to bother you. You have other people that are more important. No, no one
no.
is more important than anyone else. If you have a question, you need to reach out, because that's what we're here for. And you wouldn't give out the number like that if you didn't mean it, right?
And then in addition, if they are not comfortable, that's why we have a hotline. They have Alejandra's phone number. They have my nurse practitioner's phone number. They can even call them
Yep.
if they think they don't want to talk to me. And then eventually I get the message. Important thing is how could make sure there's some sort of a communication. I've seen this particularly when we do in the past these DVA procedures, and sometimes the wound looks worse than before it gets
Yeah.
better. And if they get admitted to another hospital, there's a high chance they will get an amputation. So when we do this procedure, we get the whole family involved. We talk to them at least 30 minutes, not only the patient, the family, explaining them that, you know, you may have more pain. The wound may look worse, but you cannot let anybody do amputation. Even if they get somehow admitted to the hospital, the family calls us and we contact the doctor right away. Hey, I did this. Please don't do this. And many of them, they get transferred to our hospital for further care. So again, communication is extremely important.
Yep. Okay, so I don't know if we have quite the live studio audience today. I don't know. I had a feeling I saw Heinz pop on. He does have a question. He's always
Okay.
great with questions. Heinz, go ahead, unmute. You can ask your question yourself. You always are very eloquent with yours.
Thanks for being on, doctor. Many years ago, I had cancer and I was in the military. So there was a tumor registry, and I think there's a cancer registry. Is there a cardiovascular registry out there also that you guys can share information? I mean, you doctors talk all
For
the time, but
PAD.
Yeah, there are,
That's a good
yes.
question.
cardiovascular
Yeah.
issues.
So there are registries, yes. PVI, peripheral vascular registries, and coronary registries, and valve registries. And that's where we usually submit all the outcomes every month to the registry. Yes. If you'd like, we can later on send you some more information about those registries. We are part of that. Yes.
Oh, and
Okay.
we have Ann Walsh that is on our YouTube, nurse practitioner Ann Walsh. She was our wound care specialist of the year.
Oh,
She has
awesome.
an app called Wound Care Pro, and she's watching and she says, "Congratulations, doctor." But congratulations right back at you, nurse practitioner Walsh. She has a
Yeah.
great app. It's called Wound Care Pro, that you can download, and she tries to keep the most up-to-date information in there with all the newest publications on wound care for everybody that wants it. Um, and Nancy, I don't know if Nancy wanted to ask about LP little a before we get to those final questions. There she is.
Hi. Yeah, I've been diagnosed with LP little a. I'm in a clinical trial with Eli Lilly. And I was just wondering what your thoughts are about that, because I'm doing very well. I do think I'm getting the lepodisiran. My cardiologist thinks I'm getting it. I've been able to get off 4 medications since January. So just wondering what
Yeah.
your thoughts are about it. I'm fighting hard.
Yes, so LP little a, it's, most of the time when we look into the risk factors for cardiac or vascular, usually we look into like diabetes and hypertension and hyperlipidemia, particularly elevated LDL, low HDL, and triglycerides. But LP little a is another component which is now we are doing more research that can also contribute to the disease process. Because some patients can even have a normal lipid panel, and they end up having atherosclerotic disease, and we think maybe it's because of Lp(a). So it's not widely used still as a risk factor like other conditions, but I think you are one of those clinical trials to show that objectively that when you are treating patients with elevated Lp(a), what are those outcomes? So I mean, I know about this, but there is not any specific medication in the market which attacks the Lp(a). Usually, we kind of start doing high intensity anti-lipid medicines for those high doses of statins or PCSK9 inhibitors, those to
The
get the
Repatha.
LDL all the way down to like 70 or so.
Mhm.
And then hopefully, yeah, as we get more information, more objective data available, that will also be part of the treatment pattern.
I was over at NCVH and one of the conferences over in Louisiana, New Orleans, and I met
Yes.
the folks at a company called Liposorber. And so for those patients in advanced stages, and they had a case they were sharing with me that a patient's limb was on the line, they had nothing else they could do, and they were able to clean out the blood, the Lp(a) out of the blood using liposorber. It's almost like a kind of a dialysis, except you're not using someone else's blood. They're just cycling the blood through this little cleaning
Wow.
machine. I know I'm simplifying
Wow.
it, but they had some clinical
Yeah.
studies there that I thought were really interesting. And they said that it's in most hospitals, but most doctors don't even know it's there. So I thought that was kind of
Yeah, it's
interesting.
amazing. Yeah. Yeah, it's
I-
amazing how things are happening. Yeah.
Yeah, I just
I don't
hope
have
that
much experience myself.
yeah, I just hope that they start testing more for this because they say 1 in 5 patients has it. And now all my family is getting tested for it, and one of my sons has it also. And his
Okay.
numbers are higher than mine. So, but I'm fighting hard and I'm doing well. And I do think I'm
Great.
getting the drug, and hopefully the FDA will approve it soon. So,
Yeah.
Yes. Well,
So
wish you all
thank
the
you,
best.
Nancy.
Yes.
okay.
We need people
So
like you to be part of the studies so we
Right.
can help other people for better treatments.
Yep. And we just launched
Yes.
PADtrials.org. So any trials that anyone hears about, we should get all the sites up there where all these trials are happening for PAD. So it democratizes access, to the information. So more patients will participate to help create the change we all want to see right down the road. We
Right.
still need lots of evidence for all these limb salvage
That's right.
procedures.
Yeah,
So
but I
Thank you,
can see.
doctor.
Oh, you're very welcome. Yeah,
And
I agree.
congratulations.
Oh, thank you very much.
Okay.
I see myself, I've been doing this for quite some time, 15, 20 years. When we started, there was very little scientific evidence. And we used to call it a wild, wild west, and everybody's saying whatever she wants to do. But now we have a really scientific evidence that you
Mhm.
could use this and you could use that. What are the long-term outcomes? So yes, it has significantly improved scientifically. We have more objective clinical data available.
So this is the speed round. 6 questions for you. We ask everyone. Number 1, describe a case that you learned a lesson from that other physicians, clinicians can learn from. It could have been a success, it could have been a failure, but share a case with a strong lesson you learned from and others could do the same.
Well, I thought about it, and I just wanted to talk about one of the cases which addresses different issues which can happen in a real clinical practice. A few years ago, there was a patient got admitted to the hospital with CLI, had a wound, and she had her own cardiologist. She had heart disease as well. So he was consulted. He came in and evaluated the patient and appropriately took her to the cath lab, and she had multiple occlusions. He tried, and unfortunately, he was unable to get through to them. So he went and talked to the family that, sorry, there is no option available, and she will need a major amputation. Family was very, disheartened, and the daughter wanted a second opinion. She said, I want a second opinion, and somehow they found my name. And we practice in the same hospital. He's my friend. Well, kind of. But when he found out that the family wants a second opinion from me, he created a big issue and went to the CEO of the hospital and saying this Raja comes and he's taking over my patients and this and that. And I had nothing to do with it. So, I mean, they had a talk with, CEO, Dr. Raja, this doctor is calling. I said, listen, told the story. So I said, well, I'm not going to get involved, okay? I'm not going to get involved. Find somebody else, okay? Because, okay, anyway. So the family was so adamant that eventually they consulted me. And I went and saw the patient, and well, thank God I was able to revascularize this lady, and she got better, and she went home. But the thing I learned from it is that sometimes you get into the situations where there are a lot of pressures from different, political issues and that issue and that issue. But we should not forget that our main object is how can we save the limb and help that patient. That guy, the doctor, hasn't talked to me since then. It's been years, okay? But
You
he has,
saved the leg.
yeah, I know. But, there are a couple of patients who eventually came to see me because he told them that go and see Raja. But he hasn't called me personally. But it's a lesson for us to learn that, when you're practicing, you're going to have these kind of issues. But, as long as you are focused, what you really want to achieve is beyond politics. So that was one of the things I learned. And the second was about amputation. This is a few years ago before we started our CLI program, and I in the hospital I met one of the orthopedic surgeon who does amputations. So I was talking hello in the doctor's lounge, and I said, well, you do amputations? Yeah, I get called and I do amputations. And he said, I just really hate amputations. It's not a good surgery. I just don't like it. Then I said, well, then why do you do it? Well, he said, well, when I get called, it means that those doctors have done everything possible. They have exhausted every possible therapy, and there's nothing else available except amputation. I said, probably that may not be the case every time. He said, what do you mean? I said, meaning that you may think, but depends upon who's calling you, how much expertise that physician has, right? So then we started our CLI program, and now we have this policy that anybody who is asked for having an amputation, they need to be reviewed by our program. And now you can go to any orthopedic surgeon in the hospital, they will not touch the patient because they have realized that, hey, not everybody is the same. Now the gold standard is the CLI program, where you have expertise from all the specialties. You send them there. It's just like going, I mean, a very smaller level, like going to MD Anderson, right? You know that you're at the right place. And if they recommend that patient needs an amputation, that means, yes, everything has been exhausted, including deep vein arterialization and the P.A.D. and all the most recent technologies available.
And that's what's really frustrating is that different doctors, and I like to drive it home, you bring such a good point up that different doctors, different approaches, different tools, they may be doing the best they can do with the
Right.
tools and the techniques under their in their armamentarium and within their skill set. But it doesn't mean that a different doctor might not have a different trick up their sleeve. And it's always worth considering, which is why, unless your life is on the line, and you always need to ask the doctor that, you should say, you know what, I want to explore the different doctors that might have a different tool because one person in one cath lab might have, let's say, a minimally invasive bypass known as PTAB, and the other one may say you're not a surgical candidate for bypass, so I don't have another option. And
Right.
it's really important. That's why I don't understand in the first story you told why that doctor would be so territorial, but I do see it all the time. It's
Yeah.
just that why are you sitting there going to the CEO and arguing for your own limitations versus recognizing this is a hospital system. We all should be working together. We should be a team and we should help where one person leaves off, the other one can come in because everyone has a different skill set and different tools.
Yeah. I totally agree. I mean, there are other physicians, they are totally opposite. They believe in a teamwork. They believe in, if myself, I mean, I don't consider I'm the best. And it happens to me, if there is something very complicated, I really don't know. I will ask one of my colleagues, which I trust. This is always good to have a second opinion. As my vascular surgeon or other guys, hey guys, take a look at it. Tell me, what do you think? Maybe we do something together. So for that, I think the main thing is back in your mind is how can we help this person? It could be
Yeah.
my family. It could be your family, right?
Yep.
It's not a thing. It's a person, right? So if somebody puts their health, put their life in your hands, it's a huge, to me, it's a huge responsibility when
Yeah.
I'm making a decision where particularly things like major amputations, right? I have to be 100% sure that there is nothing else possible. And then, as you talked about, you have to look for second opinion. That's the message I always give to everybody that,
Yeah.
even myself, if I tell you something and if you don't agree, please go for it. I'll give you a few names. Go and ask those guys. They are very reputable, very skilled, very good physicians. Maybe if they disagree, I'll be happy. So that kind of attitude is very important.
Yeah. And I just realized what time it was. I'm so sorry I'm taking now. I could talk to you forever because you're so passionate and I absolutely love it. But let me get to the question number 2. Describe a case where a patient should have been diagnosed with PAD sooner, but wasn't, and because of that presented on deck for amputation. And it's just, this is our Journey to Diagnosis series where we just try to raise awareness that, hey, if you have if they're saying arthritis, if they're saying back issues, if they're saying fibromyalgia or arthritis, you still may want to get your arteries checked.
Okay, so very interesting. It's not long ago, a few months ago, one of our, a lady who works in our office, she came and she talked to me, Dr. Raja, my mom, excuse me, she's having this so much pain in her legs. And she's been going to her family doctor, and as Kim, you were saying, and she's been told you have arthritis, you have this, and it's been months and months and months. And now she hardly walks, and I can see her. I think it was right foot is becoming like kind of discolored. I said, I think we should. Has this doctor done any kind of studies? No, he doesn't even check the foot. He just, uh, listens to you, and then, he hasn't ordered any ABIs or anything. So I said, okay, well, I'll be happy to see her. So she came to see me, and of course, she had severe vascular disease. Her ABIs were like 0.5 and 0.7, something like that. And so she already was maximized on everything. So eventually I recommended that she needs an angiogram. So
Mhm.
we recommended angiogram, but the problem is that insurance company is not willing to pay for it. Why? Because they don't think she's that bad. So I mean, it's just frustrating. And many of these insurance companies, they have these people, they have absolutely no clue what are they talking about, and they are the one who make decisions. Anyway,
Yeah.
that's the reality. So that took few months, and a time came that this lady started having resting pain and she couldn't go to sleep. I said, listen, let's do something. Why don't you go and show up in the emergency room in the hospital, this one where I work, and tell them that she has severe pain. They will call me. Then I will admit you to the ER and we'll do the procedure.
Oh my God.
Well,
You have
if
to go to
they want
those
me to do
lengths.
that,
Oh my goodness.
if they want me to do that, okay, I'll do that. So, and that's a real problem, right? So she went to the ER and they examined her. She has a severe vascular disease. She got admitted, and she had occluded as SFA and multi-level disease. We took care of everything. She stayed at like 2 or 3 days, revascularized. She had other leg also occlusion. So after she got discharged, the insurance company got all the, whatever we did. And then they sent us a letter. Yes, sure, you can do the other leg. I said, okay, now you realize that we are not just telling, we are telling because the patient has a serious issue there, right? So that taught me a lesson that sometimes you just have to fight for it. And poor patients are the one who, they don't know what to do. And they do call insurance companies. And this issue is getting worse and worse with time.
Yep.
So yes,
I,
that's what I remember this patient.
that's
And
so frustrating.
yeah.
I need to send you my latest article that I wrote for Vader.tv.
Okay.
I'm in the middle of a 4-part series. Part 1 went up last week. This week, I think, is the real hard hitter. Because it really dives into the insurance company issues. And Dr. Craig Walker, one of our amazing CLI fighters,
he's my mentor.
Yes, he just shared it today with quite the note telling everybody that they need to read the article. So that was like,
Awesome.
wow, that was affirming.
I would love to read that article. Yes.
Yeah.
Yes.
So, okay, share the story of a patient who impressed you. Patients love this story. Not sure, okay, Donna's not on anymore, but she would love to hear, and everyone loves to hear the stories because they like to know, that doctors can be really proud of people and they want their doctors to be proud of them. So, share the story of a patient who impressed you with their effort to improve their PAD prognosis through their own perseverance.
Yeah, that's a great story. So it's a young patient, maybe probably early 40s, has a long-standing history of diabetes, hypertension, chronic kidney disease on dialysis. And he developed critical limb ischemia, and he actually referred to me, had a severe vascular disease below the knee and extremely calcific arteries. So I did revascularization probably twice, and he got better a little bit. Then his condition got worse. He started having amputation of one toe and the second toe. But he was persistent. Doctor, whatever you tell me, I will do. I will not lose my leg. So eventually a stage came where the only option was doing this deep vein arterization procedure. He has a very severe small artery microvascular disease. So I did that. And then he had a long time of undergoing wound care. But every time I saw him, he was smiling. And he was always thankful to me. Dr. Raja, thank you that you did to me. I said, don't you get frustrated that so many months you've been doing this? I said, Doc, no, at least I have my leg. So eventually he has totally healed, completely healed. And so it really impressed me that this person has so much, perseverance, and he wanted to do anything possible to save his limbs. Very, very impressive. And I have many of others who are, they will do anything possible not to go through this. We know what happens once you get this major amputation. The mortality rate is sky high and other issues.
That's incredible. So we know walking's the best of medicine. So share your best motivational speech for walking as medicine. It could be analogies that you developed along the way. It could be explaining the mechanism of action by which walking helps the building of the collateral network of vessels and angiogenesis. And it could be anything that you want. Just, we love to have a variety of doctors giving us their best P.A.D. walking as medicine motivational speech.
So, I give a very simple uh, um, examples for the patients to understand what is going on to them and why we treat them. For example, when I see the patients who have severe vascular disease, and they're unable to walk, or they're walking very short distances, they have to stop. So they've been doing all these activities, but still they unable to do what they want to do. So I tell them, listen, you have this circulation problem, and in your legs you have this main highway, like El Paso has an I-10, interstate I-10. So you have this I-10 in your leg, and you see those cars driving on the I-10, they can be 80 miles an hour, right? So imagine if that I-10 has an accident or something, it's blocked, closed. And now you have to get an access road to go home. How long is it going to take you? 2 or 3 times more? Yes, doctor says, well, this is the same problem with your circulation. You have your I-10 is closed, and that's the reason you just can't walk. So my job is, how can I open this I-10 for you so the blood goes like 100 miles an hour to your foot, and you will suddenly change, your wounds start healing, you're walking. Other example I give them is, circulation, you just consider a plant. You have a plant, and you want to make it look pretty. You spray something on it, it's shiny. But if you don't give it water, it really doesn't matter how much shiny it is, it will die. So water is needed for the plant to survive. Blood is needed for your legs to survive. So comparing this, most of them, they understand. It's a very simple concept. So those are the few things I try to talk to them, and usually they understand what I'm talking about.
I love it. So share just a couple more here. Share a defining moment in your career, what we call this 6 minutes that matter. It's sponsored by Reflow Medical, so you could understand why it's called the 6 minutes that mattered, because if you've used that retractable stent, you know that it's all about the time. Got to leave that up for a little bit of time. So 6 minutes that matter, defining moment in your entire career. Could have been a moment with a mentor. It could have been a case you watched. It could have been a patient you talked to that created some sort of inflection point, a catalyst for change of anything within your career.
Sure. Before I do that, congratulations to Reflow. I was actually part of their clinical trials. Now they've been approved by FDA, and we are very excited to the second part of these studies. Anyway, that was for them. A couple of points in my life which has really changed. When I graduated years ago as an interventional cardiologist and came and started practicing interventional cardiology and general cardiology, and mostly I was doing coronary work and cardiac work. And very soon, within a year or 2 years, I started noticing that many of my patients, they come with angina, coronary artery disease, heart failure, and all that. And we treat them, but I see them, they have one leg. They have leg amputation. They can't walk because they have a problem with the circulation. So I started figuring out why. Of course, I'm fixing the heart, but these patients end up losing their limbs and they have a poor quality of life. The mortality is high, and they get referred to some other physicians, and most of the time, they are not candidate for surgery. They are not candidate for that because they have multiple health issues. They're elderly. They have a kidney disease, this and that. So one day I decided, hey, if I can fix the heart, how hard is it going to be for me to fix the leg? That was the turning point. And I said, okay, first thing is I need to learn how to do this. Okay. So, where did I go? Craig Walker. 20 years ago. That's what I'm telling you. He's one of my mentor, and I went there and I spent like 2 or 3 days in his lab, and I saw like 10, 15 procedures. I mean, the light bulb lit in my head. Oh gosh, yes. So then I came back and I started doing endovascular, and then that's how one thing led to another. And right now, my practice, at least more than 50 or 60% is endovascular, peripheral vascular, and rest is cardiac. Second thing was, this is about 5-6 years ago, and I was very busy with all this practice and doing procedures. And then we had a conference, and some very well-known physicians were there. And then that's the first time I heard this multidisciplinary concept for treating patients for peripheral vascular disease. I listened to them. I said, gosh, it really makes sense. Why didn't I think of that? Look, if we create a team, and if we work together, hopefully we'll have a better outcome. So I came back, and that's the first thing I did. I started looking into developing the multidisciplinary program. And, with God's blessing, I got the best people around me, the most passionate people around me. And now we have a great program. And as I was telling you, that we have really cut down the major amputations, and the program is growing. So those are the few really times in my life which has really made a major difference in how or what I do.
I love that. So it's beautiful, and we're so thankful that you did get involved and start to do the legs, because you're amazing and you're inspiring so many other doctors as well now, as Dr. Walker inspired you.
Oh, yes.
So now we have a fun question. And if you're lucky, I might give you our bonus question that you haven't seen yet, just because we started doing this with our friend Dr. Miguel Montero Baker and Lucas Ferrer, because they're hilarious. So I had to throw this one question out there to him. I'll get to that possibly for you. But a moment with a patient that still has you just shaking your head going, oh my God, I can't believe this patient just said that, or I can't believe this patient did it. And it's not to mock them. We're not looking to make fun of them. It's like, no, this stuff really happens, and it's a real story, and just don't do this at home.
Yeah. So, El Paso, it's a Hispanic dominating city. 84% of population is Hispanic. So a very, very strong Hispanic culture. So the reason I'm saying is that, each culture have their own ways of doing things. And one of the things I noticed, and sometimes it really frustrates me still, and that in Hispanic culture, first of all, they don't seek physician or doctor's attention until the disease process is really far advanced. Number one. Number two, that if they have any health issues, then they will ask their aunt and they ask their uncle, and most of the time they will be seen by their own, we call it curanderos, which are not the doctors, but that who all of them, they go and see that health person and they get treated. Of course, it again delays the time for them to come to us. So I've seen patients coming in with, the toes are all black.
Yeah.
And I asked them, when did it start? Oh, doctor, it started like 2 months ago. And then, I went to this person, was referred by my aunt, but it's getting worse. And now I'm this stage. And eventually, after doing all these things, they come and see us. So that kind of sometimes really frustrates me, that how can we break that? How can we break that barriers, cultural barriers? So usually what we try to do is all these awareness programs we have, where we go and reach out. We try to reach out the younger generations, their kids, their grandkids, so that they can help their elderly parents or grandparents to direct them to the right direction and not to waste too much time.
I mean, people who are here and who are usually tuning into ours are pretty savvy, because they tune in a lot to a lot of our broadcasts, but and they're always shocked to hear that we've even had cases where patients have come in with a big black garbage bag clear up to their knee, tied tightly, like with rubber
Oh
bands,
my
because
gosh.
the smell got so bad. And it was like, why in the world? Oh, I didn't want to be a bother.
Oh,
Yeah. I saw this sign
So
today,
sad.
and I
So sad.
wanted to put this up on, for PAD, but it was a sign for a suicide hotline. And the line was, the first line of defense against suicide is to say, you're not a bother. And I think that
Yeah.
should be hold true for PAD. You're not a bother. You need to ask questions. You need to get to the doctor sooner rather than later. And it's always better to be safe than sorry. And then the fun little question that I think it's a very odd question. But if you could have any mediocre superpower, what could it be? We're not talking about a cool, big time superpower like flying or seeing through walls or anything like that. This is literally a mediocre superpower, a not so cool superpower, one that solves a great annoyance that you deal with every day in your career. Like, I'll give you a couple examples. One doctor shared that he wished that he had like telepathy kind of with his or his nurses had telepathy, so he wouldn't get that call every single morning as to, hey, which way do you want the patient, which end is up. But he's like, I know they have to do it, but he's like, oh my god, it's just every morning same time, which end. You could, one other was just like, you know what, I have a fun one. I just wish I wouldn't be cold when I stepped out of the shower. There's just this consistent warmth from the hot water clear to getting dressed that I could just maintain that level of coziness. And you're going to love this one. This was an entrepreneur we interviewed who said he loved cuddling with his wife, but he wished he could remove his arm while spooning safely so that it wouldn't fall asleep.
Well, we have, I mean, I love animals. I love dogs more than cats. But my wife loves cats. Okay. So usually what happens is that like early morning, it's like, I don't know, 5, 4. I hear the sound of a cat who is just sleeping next to my wife on her side, because if she comes my side, I don't want her. So, I try to kind of push her down without letting my wife know. Because she's like extremely protective. And she said, no, please don't. She's not bothering you. Why are you doing this? So I wish that somehow this cat stopped bothering me in the morning so I can have some restful few more hours.
So nice. I have a dog that literally starting at 3 or 4 o'clock in the morning gets up on the bed and starts to walk up my legs
Here you go.
like a cat would. This little dog,
I've seen
just
it
to
in
wake me up.
one of the conferences you brought that dog. Yes, very cute, small. Yeah, you're
It's
right.
hilarious. Well, that's so fun. Thank you so much, Dr. Raja. That was really fun. Fun way to end. It's been such a serious, interview. It's a serious topic, and I love your
Yeah.
passion. I love the passion of your team. A big congratulations to the Limb Preservation Team of the Year for 2025, the Limb Savers Society. Led by Dr. Laiq Raja, your entire team, co-founded by Dr. Nurse Practitioner Lorie Henderson, who couldn't be with us today, and your entire board, all your team. It's such a great, great village that you have, surrounded yourself with there in El Paso, Texas. So we appreciate you so much. I realized in the beginning I said the Limb Preservation Society because it was the Limb Preservation Team of the Year award, but it's the Limb Savers
Society. Yes.
Society. Congratulations, Dr. Laiq Raja, and to your entire team. We really appreciate you and what all of you do to save life and limb.
Kim, you are doing an awesome job. Believe me, I mean, we always look at you whenever we need your help or whatever. So please continue to this awesome work, what you're doing, and really appreciate you giving us this honorable, award. Thank you so much.